pleased to deliver that we have Dr. R Deshpande, who is a well-known figure in this zone, and he is a gold medalist in pharmacology in his MBA, and also a gold medal in the nephrology. So to deliver this lecture, he has a lot of work in glomerular disease in oncology, because this looks at a lot of oncology work also. So to deliver oncology and glomerular disease, I request Dr. this review for this.
Thank you, Dr. Thanks a lot for inviting me to Nadia. I mean, this is the first time that I am here, and it was always like something that I thought was missing. I have never come to Nadia, so I'm very happy to be here and a part of this group here today. So thanks for that, and it was a dream to share a session with Dr. Rajabhut in Nadia. So today the topic given is oncology and glomerular disease. I thought I'll address it like this: give an introduction, speak about both ways, how malignancy affects the glomerulus and how the anti-cancer treatment that we are doing is affecting the glomerulus, and what I feel is the future. So, I served as nephrologist at Tata Memorial Hospital for 13 years, from 2009 to 2022. And during these years at Tata Memorial, I was actually instrumental in starting the dialysis there. I was surprised in 2009 when I joined Tata, there was no dialysis at a hospital like Tata Memorial. And when I left, we had 5 dialysis machines and 2 CRRT machines fully functioning. So that was quite a journey. Just tells us that how once you realize that something is required, that thing just grows. So coming back to the process, so we are speaking about how glomerular disease is either caused or related to malignancy. Is it a part of the paramyopathic process? Is it the result of chemotherapeutic or biologic agent use? And sometimes we solid stem cells. Whenever we speak of idiopathic, any term wherever we have used idiopathic, that quantum has shrunk over the years as we elucidate more and more etiologies for a particular condition. When we speak of tumors, we speak about tumor burden and processes related directly to the tumor, or products that could be released by them affecting the glomerulus in manners that we may or may not understand for now. So when we speak, we have 2 basic things, AKI and CKD. In AKI, we speak about the different toxins, the chemotherapeutic drugs, how they are affecting the immune injury, and the comorbidities that are present. Then there is an overlap which you can call as AKD, and the CKD population that we handle on a day-to-day basis. If they have malignancy, how do we deal with the chemotherapeutic agents? Which conditions become worse during treatment, and how do you adjust them? So we are going to speak only about this today, the glomerulus. That being said, there is a lot here in tubular injuries, interstitial nephritis, crystallopathy that we will not address. And a large number of you who will be practicing outside, you will get more and more involvement with onconephrology as the time goes. And a lot of references will be from these points: electrolyte disturbances, magnesium, potassium, phosphorus, so on and so forth. Hyponatremia is almost just one of the commonest references you are going to get in practice when it comes to oncology care. But what we are talking about today is the glomerular. So we just showed you a list, and it is not all encompassing. All different types of cancer and different types of glomerular disease shown different. It just tells us that we don't really understand how they are related to each other. And there are diseases which are specific for certain things, like mucin secreting tumors will have amyloid, or respiratory or lymphoid tissue problems will have IgA, and there are things we don't understand, like lung cancer will cause most of the paramyopathic genes that we come across in practice. So it's kind of, and again I'm telling you that this list is not all encompassing. This is a lot there. So what are the different ways in which a patient will have glomerular disease during cancer? One is that the tumor antigen, maybe it is mimicking something in the glomerulus and leads to the antibody-mediated damage. maybe that there are the circulating tumor antigens which are getting entrapped, because as we all know, kidney gets maximum blood flow after liver, or there could be antigen antibody complexes depositing there, or it could be an unrelated trigger like an infection or some other process. So there are two types of injuries. There is one mediated by the TH1 and the TH2 pathway. The TH1 is primarily the proliferative glomerular disease, and the TH2 is the non-proliferative. So that would be a broad-based way of looking at what kind of a glomerular disease you are going to have. So let us go over each of these glomerular nephritis that we see in practice. The common is a lot of research and development has happened in membranous over the last 10 to 15 years. And we heard some of them in the morning sessions also. And the quantum of secondary membranous in our practice is increasing. And I'm sure all of you agree to that. And a lot of that now is also related not just to the drugs but also to malignancy. So, what is difference here? Now we know that some malignancies produce antigens like L1 or thrombospondin, and the response to them leads to the position of these antigen antibody complexes in the basement membrane. So, how do we know which membranous is a primary and which one is related to malignancy? The simplest way of saying that is this: newly diagnosed membranous nephropathy, you do certain tests, the PLA2R antibody, the IgG subclass in the biopsy, and the inflammatory cells for glomeruli. Because every patient, you are not going to send all the panels. See, we used to send PLA2R, now we send an extended panel of 5, but that's only on biopsy samples, no blood possible. And so for practical purposes, you have an antibody positive for PLA2R, you have predominant IgG4, and less than 8 cells for glomeruli, from the inflammatory cells, more likely to be idiopathic. Whereas if you have antibody negative, IgG subclass is 1 and 2, and more than 8 cells, it's more likely to be systemic. That is just something for us to understand which membranous am I going to change more for malignancy. So minimal change disease, again the classic association was with lymphoma and the RS cell. That being said, now minimal change is being shown with most malignancies, whether it is solid tumors or hemopoietic tumors. Right? And any malignancy associated GN, the final proof will be if you cure the malignancy, the GN should disappear. And if the malignancy comes back, the GN should come back. Those are like Cox postulates for tumor associated glomerular disease. They are hardly going to be fulfilled in practice. Right? So how are you going to say, which one is independent of the disease and which one is related? Obviously, this is a challenge. Because whatever the mechanism, here in university with the RS cell, we speak about membrane damage, related processes with food replacement and a minimal changes. I'm just running through the different GNs before I kind of come to what I was trying to say at the end of the talk. So FSGS is less commonly associated with solid tumors. The commonest one are thymomas and RCC, also associated with breast, lung and esophageal cancer. In FSGS particularly, the data shows that it's a two-hit hypothesis. So there is a genetic predisposition and they get a second hit related to the malignancy. And so that is something to remember for FSGS particularly. MPGN, I think this is where there is a lot of, after membranous, this is the second thing where we are going to see the maximum amount of evolution in our understanding of the disease. So MPGN has been described with solid tumors of lung, kidneys, stomach, also with melanomas and breast cancer. So the entire spectrum from MGUS to myeloma and the association with MPGN has been reported, also with some lymphoplasmacytic malignancy. So MPGN or the lobular GN, as we like to call it, it is when associated with malignancy, there, except for the electron, there is not much to tell us what to suspect. So there you would need an EM necessarily to suspect. IgA is interesting because in addition to the respiratory tract mucosa or the buccal mucosa, nasopharynx, where you would expect IgA, abnormal IgA to be produced, the one association is with RCC. Now, why is it interesting? It's because some pathology samples and which showed an RCC, when the patient has an RCC, you cut that sample out, and in part of the healthy kidney tissue that is removed along with the tumor, you see an IgA. Now, is it related to the RCC or is it independent IgA which is pre-existing? Are you going to treat that IgA if the patient becomes if it satisfies the criteria for immunosuppression in IgA? So those are challenges that come in practice, and like I said, at the minute there are more questions than answers when it comes to all these scenarios. Proliferative GM, the Th1 response, is seen primarily with RCC, gastric and lung cancer. Now, sometimes when you don't know that proliferative GM that you are having, the crescentic glomerulonephritis as we like to call it, if you don't know it's associated with the cancer, you're going to start treatment with immunosuppression. Right? And unless that particular immunosuppression is also going to be effective in your cancer, we are going to see more harm than good. We should always think, whenever we see a glomerulonephritis without a clear etiology, is there a malignancy in the background? Thrombotic microangiopathy has been discussed a lot in the morning. So in this malignancy associated TMA, the ADAMTS activity is not impaired, and plasma exchange is not very helpful in these illnesses. So TMA, when it is associated with malignancy, it almost always carries a poor prognosis, and very few patients respond to any form of therapy in this setting. Paraproteinemia is the other thing after antigen which is getting a lot of attention. So whether it is classic from MGUS to myeloma, the entire spectrum including the heavy chain disease, there seems to be a lot of upcoming literature as to how to qualify these particular diseases depending on the type of light chain, depending on the shape of the fibrils that we see on electron, depending on the response in the kidney, whether it is a proliferative response or a non-proliferative response. So these are 7 of them have been shown on the screen in front of you. But suffice to tell us that the similar kind of pathology showing a lot of phenotypic expressions. Whether it is so light chain and the myeloma were discussed by the previous speaker also. But again, this tells us that your manifestation can be anything from nephritic to a frank nephrotic, from a normal creatinine to a patient needing dialysis, and our understanding of the response, whether it is a Th1 or Th2 or something more, is not yet at a point where we can predict which patient will go into which zone and how aggressive we are going to treat them. So the only thing we do is follow up, and whenever the patient shows signs of worsening, we go and treat. So to summarize at this point, there are different types of glomerulonephritis, and most of the glomerulonephritis, as we understand them, have shown associations with malignancy. Different malignancies have predominant associations with certain types of GM. That being said, initially I told you a couple of observations. When to screen for cancer remains a question in every glomerulonephritis case. So if somebody is above 60 years of age, somebody has a thrombotic event, history of smoking or alcohol abuse, hepatitis B, C, or any immunosuppressive uses in the past like cyclophosphamide for FSGS or something like that, you must make an attempt for screening medicine. How will you screen? Not just the family history, examination, lab, ultrasound, age-specific screening for cancer, mammography, and at least a fecal occult blood test. So a minimum screening for this much is advanced. Serology, as we said with membranous, that's primarily where the serology is more helpful than in other conditions. So that's where we stand as of now when we speak about secondary GM associated with oncology disease. But the bigger thing now that all of us will encounter in practice is association with drugs, because as you have realized, the number of agents used in oncology practice are expanding every month practically. So different mechanisms of injury varying from direct nephrotoxicity to immune mediated or even vascular insults, all of them lead to some form of glomerular disease. So this is a simple classification for oncology drugs in practice. You can classify them as cytotoxic, which primarily includes which we understand like the alkylating agents, platinum compounds, and antimetabolites, or the newer ones, which are small molecules, which are tyrosine kinase and protein inhibitors, the PARP and CD42, I have also not understood much yet. Large molecules like monoclonals and immunotoxins. So, alkylating agents like cyclophosphamide, and I have been told that some of my oncology friends that in the next 5 to 10 years, practice of oncology will no longer include any cytotoxicity. It's all going to the immunotherapy. So, I think more or less that's where the trend appears to be. But the age-old medicines that we have used and we are still using, like cyclophosphamide, in addition to hemolytic cystitis, we know it with certain GNs like membranous FSGS and even a lupus-like illness it can sometimes present. The platinum-based agents, the important thing here is in addition to FSGS, the other disease that they are involved with is thrombotic microangiopathy. So the presentation is usually that of a nephritic illness when you are associated with, so we are talking only about the glomerular part of the disease. We have left alone the tubular illnesses, injuries which are much more likely with this class of drugs. And like I showed you in that small pictorial, that most of the references in practice are going to come from the tubular injury. So they are far more frequent and far more common than seeing a thrombotic microangiopathy with cisplatin, which will be like, maybe once every 10 years you might come across something. Methotrexate or antimetabolites, the important is immune-mediated GM, because we have seen that methotrexate as a cytotoxic agent, associated diseases are minimal change, lupus-like nephritis and interstitial nephritis. Exactly what it is supposed to cure in a lot of patients also. Gemcitabine has been associated with ovarian and pancreatic cancer treatments. The renal problem is thrombotic microangiopathy. So this is the pictorial trying to unify these two. So drug-associated illnesses, whether it is when it is vascular insult, is primarily related either to adhesion strategy, VEGF, direct toxicity, or complement-mediated toxicity. So one of the four leads to the vascular injury that presents in the thrombotic microangiopathy. So what do you do in such situations? And would you want to stop the drug, consider plasma, give certain drugs like eculizumab? Because you are being called to manage the aggressive renal injury in a TMA associated with malignancy. So at 2015 or 16, when I was at TMS, we published the data of sunitinib-induced TMA, 13 patients in all. And in those patients, the drug that actually helped was steroid. Wider at 1 mg per kg, we had a resolution of some 70% in withdrawal of drug with addition of steroid. Whether the withdrawal of the drug was a treatment or whether the steroid is up for discussion. So that is what we actually did in those 13 cases when we had sunitinib-induced TMA. So that was, TMA was far more common with sunitinib than the current day drugs that we are seeing in RCC. So this spectrum was where very few people were getting into medical oncology. Here when a lot of people are venturing into the same. And as you see, there is a galaxy of drugs. Some twisters, just reading the names is difficult. But a lot of drugs coming into practice, and we need to be abreast with the name, the function, and the kidney injury associated with these drugs. As this specialty is expanding, and our role as a supportive part in the treatment is also expanding. So, targeted therapy agents like tyrosine kinase, sunitinib, I just mentioned to you about sunitinib. So, sunitinib and sorafenib both were implicated in TMAs, proteinuria, hypertension, renal failure. Proteasome inhibitors like bortezomib, again FSGS related to podocyte injury. Now there was always this thing, bortezomib and even the bisphosphonates used in all of the patients with myeloma. They present with this kind of a pathology on biopsy. And it's difficult to say which has led to the same, because they want us to know whether to stop the bortezomib or continue. So whenever I am given a reference for nephrology, it's always a question mark how to answer. What is the right thing to say? So these different immunomodulatory agents, thalidomide, lenalidomide, also associated with thrombotic microangiopathy. Alemtuzumab not available with us, but it has been shown to associate with anti-GBM antibodies in addition to membranous nephritis. This is Campus, which never got into India. VEGF inhibitor is important and deserves mention as a separate class from everything that we are talking about right now. So when you speak of VEGF, you speak of VEGF itself, you speak about drugs that block the VEGF receptor like ramucirumab, or you speak about TKIs or the VEGF receptor. And I'll mention to you why it is important. Because these drugs are now used in a variety of scenarios from RCC to colorectal, gynec, lung malignancy, and even non-small cell lung cancer. So what does it do to the kidney? It causes proteinuria, systemic or renal limited TMA, and some glomerulonephritis like minimal change or FSG. But what is more important to your clinical practice is it causes dose-dependent hypertension. Okay. So this is important because this hypertension, this is the mechanism why it possibly happens, as to why they get hypertension. But from a clinical perspective, how common is the hypertension? So the incidence is as common as 30%. And high-grade hypertension, grade 3 or 4 hypertension, occurs in 4 to 7% of population. There are case reports of patients getting into hypertensive crisis with a VEGF inhibitor. And in a real-world scenario, they suggest that the rates of hypertension on these drugs could be as high as 45 to 80%. So it's very important to note this. And only some cases, isolated cases, will you actually consider stopping the drug. So most of the time we are going to increase drugs, whether it is calcium channel blockade, RAS inhibition. As long as the patient has controlled hypertension and subnephrotic proteinuria, it is safe to continue the drug. If the patient has grade 4 hypertension, worsening nephrotic syndrome, or a thrombotic microangiopathy, it is time to stop the drug or the treatment. That's an important take home, because this is something that's very relevant to day-to-day practice. Immune checkpoint inhibitors, that is now the another class of drugs which you are going to see a lot. There are basically 3 types. So PD1, PDL1 and CTLA. So all of these names will be common to you by now in practice. Pembrolizumab. We recently had a case of pembrolizumab associated hypophysitis, which we wrote up about. Presented with hyponatremia to start with, and then the whole thing. So, and all of these, atezolizumab, ipilimumab, all of them have been associated with renal injury. But more important is they have caused a significant shift in patient survival when it comes to metastatic malignancies like lung cancers, RCCs, melanomas. So these drugs are here to stay. They are helping patients live longer. So we have to learn what are the renal side effects and how can we manage these renal side effects without withdrawing the drugs. That cannot be the first response, should not be stop the drug, because these drugs help them live longer. The first response should be what can I do differently at this point. So this is how these things work. The immune checkpoint inhibitors. Basically, we don't have to give you the exact details of it, but this is still showing us where it is working. And what's important for us to understand is that because these checkpoint inhibitors are restoring the balance, the T cells are now able to kill the tumor and buy you time. Right? What is happening in the kidney? So what is happening in the kidney is what is called as off-target immune-related adverse events. So off-target immune-related adverse events are primarily seen with skin, endocrine, GI tract, and teeth. So the kidney is actually the least of their problems. The kidney problem in immune checkpoint inhibitors is not even 5%. It is around 1 to 2%. But because of the increased usage of these drugs, the total number of patients on these drugs now far outweighs any other kidney. Because of that, we are getting more involved in managing the side effects of these agents. So, mechanism could be autoantibody, T cell infiltration, or inflammatory cytokines such as interleukins, which are being released by the activated T cells. So how would it present? It can present as both nephrotic syndromes as well as nephritic illnesses. And in patients where they have done a biopsy, you are going to see something like amyloid, membranous, and in nephritic presentations an IgA, thrombotic microangiopathy, or a possible vasculitis. This tells us again that our entire understanding of glomerulonephritis is, we'll have to have a rethink, because we are seeing all the possible mechanisms that will evoke in these injuries. So whether it is VEGF or immune checkpoint inhibitor, this is very important. So if a patient starts with normal kidneys, no proteinuria, no hypertension, normal GFR, the risk of them having a significant kidney problem over a period is very small. If they have any kidney injury to start with, whether it is proteinuria or low eGFR, the worsening is 23%. eGFR decline could be as high as 40. And in patients with diabetes, the worsening is even more. So if a patient has a kidney problem or diabetes to start with, then tolerating the VEGF or immune checkpoint inhibitors is poorer as compared to patients who start on a clean slate. So these are other targeted therapies like mTOR, BRAF inhibition, BCR-ABL inhibition, and it kind of becomes same when we speak about it. Similar glomerulonephritis, tubular injury. So some things have to be remembered with some illness, like hypophosphatemia with the BCR-ABL. So when you see somebody with imatinib or dasatinib, you think of hypophosphatemia. Some things are more important or more common than others. So how do you know what is the injury because of? Is it because of the tumor or is it because of the chemotherapeutic agent? So they have used the terminology is CT and CT. So K and C. So the K is the cancer and the C is the chemotherapeutic agent. So here we are coming to biomarkers, and this is where the next step feature is. So biomarkers will play an important role in providing early and accurate identification of type of kidney injury, as our old tools like creatinine and eGFR may not be enough here. So the NGAL, the KIM1 and the interleukin-18 in the urine, they are more in favor of the CC or the chemotherapeutic agent. Okay. Whereas interleukin-18, it's important whether it is seen early or late. Early it could be related to the K or to the cancer and not to the chemotherapeutic agent. Other tumor markers like LDH, beta-2 microglobulin, urinary angiotensinogen are for the K or the cancer related. So how do you know when something happened, whether it was because of the drug or the cancer itself? You will not look for it before we started. So then these are drugs that might help. Circulating tumor DNA, particularly in patients where we are following with treated renal cell cancer, it's important to know that we can have an early detection of metastatic RCC. Exosomes, we have not any use. So this is important and relevant for the entire audience. When would you biopsy a cancer patient? That is the question. Would you biopsy just because they are worsening proteinuria? Would you suppose somebody on a VEGF is having hypertension and worsening proteinuria? Do you need a biopsy? Or do you need, suppose somebody on sunitinib comes with a TMA, do you need a biopsy? So actually these are not patients you are keen to go ahead with a biopsy. It's a very morbid patient. And unless you are going to make a change in the treatment after your biopsy result, you don't really want to rush in with the needle, right? So it's a very tricky question, because this always used to be a bone of contention at PMH, because they would say, why don't you biopsy? And we are like, okay, nothing will change after I biopsy, right? Because you know what is happening there. So only newer drugs we were happy to biopsy because we were still trying to understand what's happening. Other than that, in known etiology, so again, where should you biopsy? You should biopsy if the patient has an atypical or unexplained clinical course, where you are not able to understand what is the reason behind the kidney injury. You should consider a biopsy. You should consider a biopsy for coexisting renal conditions or other kidney diseases. A patient has a malignancy, is on a chemotherapy agent, doesn't mean that he or she may not land with another kidney disease which is not related to the current scenario. So those conditions you should see. The other important thing when to biopsy is if there is no response to steroid. Suppose a patient on a PD-1 like a nivolumab comes to you with proteinuria. You are given a course of steroid, 1 mg per kg Vizolone for 6 weeks. No response. Patient is also diabetic. Right? Now you should consider doing a biopsy, because now you want to know whether the proteinuria was because of diabetes or whether it is because of your drug. because that will decide whether to continue or stop the drug. In these patients, the only question that is of importance in practice is will you continue the drug or stop? So that is what is important to all of them. So future, I mean, these are just some thoughts, really, but genetic, personalized, so now their precision oncology, they keep on speaking a lot of precision nephrology. Then maybe, we can have genetic testing for polymorphism in the enzymes, like CRP enzymes. You can predict who will get a cisplatin-induced nephrotoxicity and who will not. So these things, as they become bigger, our usage of these agents for immune checkpoint or chemotherapy-induced nephrotoxicity might actually help us predict which patient is likely to get a kidney injury and who will not during the course of the therapy. It will also help us to choose the agents to treat these problems in the kidneys as they happen during the course of these diseases. Another important thing is, I'm sure all of you are aware, for the students, I mean, a lot of the drugs that you use so commonly in practice today, like rituximab, are basically borrowed from oncology, right? So if you keep abreast of all the newer drugs that are coming, maybe we'll be able to borrow more and use them for our patients' benefit. Particularly antifibrotic agents, like they seem to be a big thing now in practice, and we all know that instead of doing everything, the worst thing happens because of ongoing fibrosis. The safer ones is what we need. So as we go, with the advent of these immune checkpoint inhibitors, CAR T cell therapy, and the monoclonal antibody, more and more nephrologists will be involved in managing immune-related kidney toxicity in these patients. So this is definitely a branch where younger kids can aspire to be playing an important role in as it evolves. CAR T cell, we are actually not touched on that, but it's again important because the cytokine release syndrome, which you see with this powerful treatment, you see, injuries like proteinuria, renal failure, even pathetic GN, and all of that. So AI, big data, it's coming in a big way in cancer care, and you can extrapolate same to our treatment to predict. These models will help you predict which patients are more at risk and which are likely to get into kidney injury. So like I said, the expansion of nephrology is truly critical in cancer care is already happening all over the world now. People are trying to specialize a lot into onconephrology, and me going into onconephrology was an accident because there was no oncologist at Tata Memorial, and the director Yuni and she said, "Can you please come and help?" And that's how it started. But this is something now which is like a career option for people who would like to get into it. So this is how an onconephrology typically works, and this is something I have borrowed from Vikram, who was one of our first residents from Jaslok, who went into onconephrology in the US. So they do a lot of this now with multidisciplinary collaboration and trying to manage patients from the renal point of view when they are on cancer. So definitely we need to make sure a patient who survives cancer will have a good life and good kidney function. Having optimal kidney function also helps these patients become eligible for chemo or immunotherapy to improve their survival. And this is something that all of us need to remember. Thank you so much for the attention.
Thank you, Dr. Rishi, for a wonderful lecture. We all know that we are bone transplant patients in the last year seeing 50% difference. So even the oncologists, they treat the disease for 30 days survival. So they're all sicky patients. Again, whenever they are sick, the kidney also gets a second. It will be the people who are looking after that. So, and a lot of trials are also coming up with all multiple agents, and it is very, very difficult in sicky patients that they'll have more and more comorbidities and they will have an EKA also. And even the electrolyte difficulty is one of the most important. I think the house is open for
a few seconds. Well in time. You can take one question from the house.
So the claim is that carboplatin has lesser nephrotoxicity as compared to cisplatin. But in practical, I think the dose and the frequency of usage, the patients who have higher doses of carboplatin or multiple need of the drug manifest quite similar to cisplatin. So all of these three, cisplatin, carboplatin, and oxaliplatin, if you look at the chemical compound, the group that causes kidney injury remains important in all the three.
Thank you, sir.